I'm fine, thank you. I just want to apologize once again for this delay. This is somehow it appears that presentations are extremely well and with huge interest, and we had an extension of the program for a while. And this is, I want to apologize to you and to our industry partner, Boston Scientific and Vicor. And I just want to introduce you as a presenter of this presentation named Deep Brain Stimulation combined with Radiofrequency Lesioning. Professor Ali Savas is professor of neurosurgery from Ankara, expert in the field, and he will give us a presentation on behalf of our industry partner, Boston Scientific. So Ali, please, floor is yours. Apologize once again.
Thank you very much, Lucas, for your kind presentation. And I must express my gratitude for invitation by Serbian Neurosurgical Society to such a presentation. And also I'd like to send my greeting to all Serbian neurosurgeons. Yes, the topic is a little bit different, and some young neurosurgeon may ask that is there still a place of lesioning in the deep brain stimulation era? And I first would like to say that it's this presentation is that does not aim to neglect the importance of neurostimulators. That's our all opinion that the neurostimulators are the greatest advance in the treatment of movement disorders in the recent decades. Indeed, we are very lucky to work in that era because there were such limitations in the lesioning era, and we could overcome the difficulties with modulation effect and bilateral placement and bilateral effect, and it seems to be safer than lesioning. There is no doubt about it. But there are still concerns about the troubles and problems. Complications or troubles exist even with deep brain stimulation, and I tried to summarize it that dependence to hospitals and physicians living with a complicated foreign body, effect of the magnetic fields, need for reprogramming the parameters, even chronic ineffectiveness, although we say that the side effects and complications are reversible. On the other side, treatment is not permanent. And need for changing generator, reoperation, and also lead migration, dislodgement, fracture of the cables, and late skin erosion, infection, fistula, open circuit, and also what we can do for inoperable cases. The problems are not so that deep brain stimulations may not be effective in such cases, especially in cases with secondary dystonia due to brain damage, especially such cases with cerebral palsy. It doesn't seem to be so much effective in cases like primary or genetic dystonia. And there are also problems with unilateral severe tremor dominant Parkinson's disease cases, where we could place the electrode, thalamus or subthalamic nucleus, and also reduce known effectiveness of the deep brain stimulation, especially in essential tremor cases, and also lower recovery rate in dystonic tremor after DBS, what we can do. When we look at the lesioning side, we have got now case control studies with deep brain stimulation. Indeed, most of them historical series that there is no so much evidence-based proofs of lesioning. since they are more older publications. And finally, when we look at that, many important questions and controversies regarding lesion therapy remain unanswered. And additionally, studies on lesion therapy are not easily accepted for scientific publications and presentations. That's the fact. And there is a hidden pressure not to do it. I don't think that it's a scientific pressure, but it is still there is. And the question is that after that
Videos and
introduction,
habits of neurosurgery.
um, the question is that is there still a place of lesioning for movement disorders? In our opinion, or opinion of some neurosurgeon, yes, I think. In our clinical practice, we are doing lesioning in about 5% of the cases, but only, I should note that only in selected cases, not only because of it's easier or less expensive, but because it has some advantages where when compared or combined with deep brain stimulation. But I would like to say again that only in selected cases. And the usage is much limited according to deep brain stimulation. On the other side, the traditional radiofrequency lesioning are still performed in traditional clinics. Radiosurgical lesioning and telemetries are still indicated, especially in inoperable cases. And also, there's more research and developing field for focused ultrasound lesioning. And this picture shows that there are still a debate or concern about more lesioning. Why is that? Um, from our view, from our practice, thalamotomy lesioning procedures are by number reduced or percentage, but especially may be indicated in unilateral tremors. And in such cases, just as a scenario, there are such cases. If a case came with unilateral dominant tremor with Parkinson's disease, where we should put the electrodes. Of course, if you put the electrodes in the thalamus, you may control the tremor, but most probably they will progress bradykinesia over years. What we should do, it's not so easy to do for electrodes and additional electrodes to in the STN. And our strategy is to do in for such cases to perform first telemetry, follow up, and later STN-DBS. The results seems much better. Of course, STN-DBS controls tremor, but not as much as thalamic procedures. The other more difficult field is the cerebral palsy. What we can do more for them on in case we know that the deep brain stimulation is much effective. And also unilateral dystonic tremors do not respond so well as much as Parkinsonian or essential tremor cases. What can do more? And some patients, when we discuss about the device and generators, may not wish to live with a complicated foreign body. And also, multiple sclerosis tremor is another problem that deep brain stimulation may control at the beginning their tremors, but in their follow-up, there's a great percentage of dissatisfaction and recurrence of tremor in follow-up. It's another thing that even in the perfectly placed deep brain stimulators, in following years, there may be failure in effectiveness. What we can do more, these are realities for all neurosurgeons performing deep brain stimulation for me and others. And when we look our series with telemetry in the pre deep brain stimulation era, there is a strong effect in control of tremor as much as deep brain stimulation. And the other thing that also not only tremor, UPDRS scores are corrected when it's performed unilaterally, even when the lesion is extended to the caudal zona incerta. Also, they have a daily living scale recovery. They are facts. Also, there are and some other authors observed ipsilateral effect in tremor control, and even mid somatic symptoms like head tremor. There is some recovery. It's useful in that. And also, this real case, I mean, came to us with these such cases are rare, I accept, but they exist with unilateral severe tremor and bilateral bradykinesia. And we thought that if we perform only STN DBS, we could control bradykinesia, and the severe tremor unilaterally may not be affected as much as any thalamic procedure. These are critical cases. And for this case, we performed bilateral STN neurostimulation, and in the same session of the surgery, we added a thalamic lesion there, as you see here. I think this one is a unique case, and the results is optimal. Tremor completely abolished and also benefited from STM nerve stimulation. And we think that only deep brain stimulation may not be enough to control such asymmetric problems. These are interesting from this the unilateral palliatomy cases before the STM DBS era. That's the results of the tremor posture of palliatomy cases, and also that's the STM neurostimulation cases. Interestingly, there is a parallelism between them, executive tremor control, and STM neurostimulation suppress the tremor much effectively than palliatomy. It's maybe expected, but when we look at their follow-up, the result is that STN-DBS and unilateral palliatomy results shows that a symptomatic parallelism except tremor control. But however, STN-DBS results are remarkably better and more long-term when compared with unilateral palliatomy. And therefore, we do not perform any more palliatomy for Parkinsonian cases. It's open that STM-DBS is much effective and long-term control in Parkinsonian symptoms. And that's another field that when we say that what we can do cerebral palsy and other things. And we think that the problem is not only related with the nucleus and other things. And we enjoy to copy or try to repeat the historical procedures, and such L-shaped lesions which holds motor thalamus and caudal zona incerta, campus forelli, which may be called campotomy, but only not caudal, but all zona incerta anteriorly. This series will be published in Neurosurgery, I think in about 1 or 2 months, accepted. And the results seems to be remarkably better than on other procedures. And of course, such configuration, as you see here in postoperative MR scanners, a telemetry electrode and also a curved one to control it, and both electrodes make such L-shaped lesions. Do they work indeed, and do they not cause any severe complication? Let's look at it. Such procedure is we performed, especially in such cases which DBS is not so much effective. I mean, DBS is maybe effective, but the electrode configurations are not enough to make such geometrical effect. That's the problem, I think. And future developments in technology, I think, may cover not only the nucleus of thalamus or SDN, also the white matter as historical targets, and even zona incerta. It's much complicated region and omnipotent effect in controlling dyskinesias. And in these problematic cases like secondary dystonia and dystonic tremor and cerebral palsy cases, we routinely performed it. And in such like case, as you see, it's a cerebral palsy patient, and also it was a pallidal stimulator, deep brain stimulator placed there, correctly placed. I mean, we controlled everything, but it doesn't work as expected. And we performed additional thalamotomy and campotomy, and with side outlet electrodes, additional lesioning, and it showed an effect additional. That's another patient with cerebral palsy and hemidystonia on her right side. Most possibly, only a pallidal electrode, DBS electrode, may not be effective for such case. And after, after the procedure, you see the double lesion and configuration, holding motor thalamus, zona incerta extensively, and also campus foramen, and complete control, more than 10 years for the case. This case is also hypoxic bird and dystonic tremor on his right hand. And again, extensive lesioning with insight and thalamus, complete control of the dystonic tremor, and followed more than 15 years. And the result. For such secondary dystonic cases, around 75% satisfactory results for that. I mean, we need to have such coverage. I don't think that the directional even may sense effect so anteriorly in addition to the motor thalamus. And interesting that in the cases that this dystonic tremor, the control is more than 80% for in long term, and we need to think again for by every meaning what to do more. And I think that it is not completed, and we may do more when we look at the historical literature. And from our results for thalamotomy, is it dangerous? I don't think that it's risky, and it's remarkable complications is less than 1%, and especially in cases with comorbidity like vascular insult and others. For such big lesioning with combined lesion, the complication, minor complication, is around 2%, and it seems to be very safe. I mean, as I have tried to express at the beginning of my presentation, I don't mean that lesioning is better than the deep brain stimulation. It's not alternative, but maybe complement techniques of each other. And of course, we should think um, more sophisticated about combining the techniques, and we will see what will happen in the following years for development of these techniques. And thank you again, Lucas, for inviting me, and thank you for listening me.
Is the most internet is going. Ali, can you hear us?
Yes.
Yes. Yes.
Yeah.
Yes.
Yes.
Continue, please.
Excuse.
Ali, you have some difficulties with internet or something like that.
No.
We cannot see your screen is moving. We can hear you. We can hear you, but we
Yes.
cannot see that your screen is moving.
I can follow you. There's no problem with my internet, I think.
No, just try to go to the next slide. If it is not possible, you can restore your presentation.
Yes. Couldn't you follow all of them?
Yeah, you can continue from your slide when you stop. Yeah.
Which one?
Last one.
I see. Okay. Could you follow the previous one? Yes.
Yes.
Okay. I will summarize it again. Do you can you see
Yes.
the slide? Yeah.
Yes.
Yes. Yeah. I mean, as a conclusion, it was a conclusion that uh, I don't mean that the brain lesioning is an alternative, but DBS, of course, has certain advantages. But these techniques, if we combine as a complement of the techniques, we may get better results. And we will see what will happen in the following years to get more and better results, because we still have got problems with DBS as well. We should develop the electrodes more, perhaps. That was my conclusion for this presentation. And thank you for inviting me and listening. Thank you very much, Lucas.